Concepts of Caring Part 1, Martha Olson, Introduction to Nursing Concepts for Iowa Lakes Community College. Our objective is 171, discuss caring behaviors related to the nurse-patient relationship. We will be using Chapter 7 and 24 in Potter and Perry for this lesson. When we look at what is caring, we know it is central to nursing practice. We have to ask ourselves, can we care when we have increased demands, more pressure, more time constraints in healthcare? We're caring for more critically ill patients. We have heavier loads. We have to do more documentation than ever before. Have we lost the concept of caring? So as we explore this chapter in this unit, we will be looking at many of the concepts that go along with caring. What are caring behaviors? As a professional, we know that it is the framework for our practice. It has practice implications for transforming nursing practice. When we look at the organizing framework for the ADN curriculum at Iowa Lakes Community College, we can see there are three parts to that. One is nursing process, another is human needs, and the third one that is the center of our framework is caring. When we look at caring, we know that it is about nursing and that we care about people or we wouldn't be in this occupation. When we think about things that we care about, it determines what matters. You know, if I care if my house is clean, if I care if my hair looks nice, do we get good grades? Do we care about having fun? And it's a personal concern for another person, event, or thing that gives us motivation to want to do things better, to make it better for them. When we look at Watson's transpersonal caring and his healing theory, we look at page 81, where it focuses on individuals, and we know caring is sensitivity, it's respect, it's that high moral and ethical commitment to another person, because we know that caring creates possibilities. And as we look at hospice nursing, we know that caring is a central feature of that. Care before cure is often written, and it preserves human dignity. Our second theorist is Swanson, and he looks at the theory of caring in knowing that we have to understand an event, and every event has meaning in life. When we look at Swanson's theory of caring on page 81, we know that we see and do all of those things with our patients because we care for them. Leninger was the last theorist that the book talks about, and it's about culture. And we know that care is needed in all cultures to recover and maintain health and life practices. And as we look at a culture, it helps us to understand why things are more important or why caring might be different in that culture. In our nurse-patient relationship, then, we know that there is the helping and the friendship. Helping is therapeutic, and friendship is sympathetic. It's not as therapeutic because it needs both people. So if I'm in a helping relationship, I don't talk about myself and my needs. I am there to help the patient gain teaching, gain understanding, to understand their medications. Where a friendship, I call my friend on the phone and I share things and she shares things, and both of our needs are met. And so we have to remember the patient's perception of caring, establishing that reassuring presence. Sometimes it's not saying anything, it's silence, but it's being present for that person so that they know I care. We recognize each individual as a unique person, and we keep a close attentive eye on that patient. You know, a caring nurse is one that comes down more often or takes care of needs or anticipates needs more often because they care about them. More satisfied with care when the patient perceives their nurse is caring. And so hospitals are looking at hiring caring people because we know that that will influence the satisfaction scores for that hospital. Our phases then of that relationship, box 24-4, our pre-interaction is before we meet the patient. It's looking at the chart. It's anticipating their health concerns. What will they need? Their skin is at risk for skin breakdown. I'm going to put an air mattress on the bed. During the orientation phase, we get to know the patient, what are their expectations, identify their goals, help prioritize the needs, let the client or patient know that, you know, I'm here as a nurse and that the relationship will end when they are well and discharged. And the working phase is where we give the direct care. We educate, set goals, use therapeutic communication skills. And our termination phase then is to remind the client that the end is near, evaluate the goals where they met, partially met, not met, and then get that transition into the next caretaker. With a nurse in that professional relationship, we have to remember there's a time frame. It's very goal directed toward that patient, and we have to respect confidentiality. We have to be non-judgmental in our acceptance of all clients. And when we share about self, a very skillful nurse uses good judgment about what to share. If a patient asks me about my family, do you have children? I don't go on and on about my children. I try to answer their question in a respectful phrase and then bring it back around to them. I have 3 children, they're all in college. Tell me about your family. Because again, it's not about me, it's about the patient. So as a nurse, we provide minimal information, or we deflect with gentle humor or a kind way of getting back to them. And I think patients say or ask things about us because they're caring to us as well. When we look at the nursing role, then, as I said, we have to maintain confidentiality. When we look at our crossing boundaries, we want to maintain our professionalism by not giving them our phone number to call at a later time. Leave your issues at home. I might have had a big fight with my husband before I left for work today, but as soon as I clock in, step into the uniform, and am at work, I have to be professional, and my mind has to be at work so that I can be there for the patient. As we look at the patient and family perception, this is really Madeline Leniger and her theories, where she talks about care as that essential human need. Everybody wants and needs to be cared for by another person. Studies have found that many cultures, nurses need to understand the cultural behaviors and why patients do things as a result of their culture. We have to focus on building relationships that allow us to learn, what is important for that client. How will you demonstrate caring? Every nurse will do it differently, but we have to remember that we demonstrate it every time we enter the patient's room. And what is an example of caring behavior? When we close the curtain, cover the patient while we're giving them a bath. For a nurse manager, trying to promote more caring behaviors in their staff by allowing staff to maybe have time off, to be that nurse manager that listens when a patient has died and the nurse is really distraught about that. Providing presence, sometimes just being with the patient and sitting and holding their hand is showing caring, even though I'm not really saying anything. Being comforting, being calm, speaking quietly and directly to the patient instead of asking the family about them. All of those things are going to demonstrate caring, and every one of you will demonstrate caring in maybe a little different respect. The care we give is spiritual. I'm very fortunate to work in a hospital that has a religious basis, and spirituality is an important part of our care that we give there. Family care is important because we know that the family is grieving and going through a lot of dynamics as well with the disease, with the diagnosis, with the surgery. Touch is important. Sometimes your touch is just holding their hand or giving them a little pat on the shoulder. Sometimes our touch is through giving a gentle bath, soothing strokes with the washcloth. And then our healing environment is such things as keeping the noise down, not turning the bright lights on every time we enter the room. As we think about our nurse caring behaviors as perceived by the family, we have to always remember that the patient is the one that we're there for. We're also there for the family, but sometimes due to confidentiality, we can't share things unless the patient wants us or explains themselves. So we keep the family member informed as much as we're allowed to with HIPAA rules. We try to make the patient comfortable. We try to answer the call light as quickly as possible, teach the family, allow the patient to do as much for themselves as possible so they can get stronger and know how to do things before they go home. When we depersonalize, that I remember a surgeon that called every nurse in the facility honey. And I always felt very depersonalized by that. When we do that to our patients, it makes them feel that same way. They're an object instead of a person. If we talk about patients as the appy in room 52 or the older gentleman in room 65. So we need to call them by name. They prefer that you call them by their Mr. Jones, Mrs. Jones, and if they say, "Oh, call me Mabel," then they have given you permission to do that. I'm terrible with names, so sometimes I really have to struggle with remembering what their name is, but that is an important part. So some of the challenges to caring we need to think about. Over-involvement. When I go in every day that they call me because they're short of help, and I know that if I don't go in, cares won't get done. Sometimes we can be overly involved in a client's care or even their personal life. Under-involvement also interferes with caring when we don't follow up or check up on our patient. Time is a challenge. We can't do it all, and sometimes we have to selectively choose what we have time for, and it might be passing our meds and getting the meds done on time, when all we really want to do is go sit with the patient that was just diagnosed with a terminal illness. Stress, sometimes we have to cut corners to survive. Technology has been huge lately as our staff has tried to learn computer charting, new monitors at the bedside. All of that takes a drain of you, and you walk in a room with a computer and you don't even look at the patient or ask how they're doing. You're staring at the computer trying to get your charting done on time. DRGs or insurance coverage. When we look at burnout, we can see signs in nurses, in colleagues, and we have to help them to identify that, to get some time off so they don't burn out and leave nursing, because that is a huge problem for us in this profession where we care a lot and sometimes things don't come out the way we want. When nurses are able to affirm themselves as caring individuals, they achieve a meaning and purpose to their lives. Caring is a motivating force for people to become nurses, and it becomes a source of satisfaction when nurses know they have made a difference in their clients' lives. So as we end this PowerPoint slide, we think about what are the challenges of caring, what way am I going to show caring to my patients, and also what way am I going to show caring to my coworkers and other people that I work with in this very stressful environment we call healthcare. This ends our part 1 of caring.